It is with the greatest pleasure that we bring you the fourth lecture in the McGill Palliative Care National Grand Rounds series. With the generous support of 9 local hospital foundations and Pallium Canada, we intend that this initiative builds on the historic contributions by McGill University to the field of palliative care by providing a novel means to disseminate the latest innovation, research, and ideas in our field to places across Canada and beyond, who may not typically have access to the types of speakers who typically present within the walls of our academic institutions. Before welcoming my colleague and National Grand Rounds Course Director, Dr. Stephanie Gingras, to walk us through the accreditation-related information for this lecture and the National Grand Rounds program, and before we then ask Dr. Jeff Hall to introduce this neuro-supportive care lecture, we wish to acknowledge the land on which this lecture is given. And while I'm pulling up the next slide, I'll just say how personally delighted I am to have Dr. Kreutzfeld with us today, because she is a great friend and a wonderful leader in our field.
Thank you, Justin. Bienvenue à tous. The members of this committee and their relevant declarations include Dr. Justin Sanders, who has relationships with La Maison Saint-Raphael, the American Society of Clinical Oncology, and Connections, Inc., and who has received honoraria and grants in recent years from the Oklahoma University of Health Sciences, the Oregon Health Science University, and Pancreatic Cancer Canada. Dr. Arjuri Tsimikalis, who discloses a relationship with and grants from the Shriners Hospital for Children. Dr. Olivia Nguyen, who acknowledges an association with la Société québécoise des médecins de soins palliatifs and a research subvention from la chaire de la famille Blanchard pour l'enseignement de la recherche en soins palliatifs. Dr. Naomi Goloff, who reports relationships with the Canadian Society of Palliative Medicine and grants from the Kindred Foundation and l'Association québécoise de soins palliatifs. Dr. Zelda Freitas, who indicates grants and relationship with the Canadian Centre for Caregiving Excellence and with Nova Montreal. And Drs. Janelle Walsh, Aurel Schuker, and myself, who have no conflict of interest to disclose. Here we, whoops, sorry. This series includes sponsorship from the Cedars Cancer Foundation, the Hope and Cope Wellness Center, the Jewish General Hospital Foundation, the Montreal General Hospital Foundation, the Montreal Neurological Institute, the MUHC Foundation, Pallium Canada, St. Mary's Hospital Foundation, the Montreal Institute for Palliative Care, a branch of the Teresa Delard Palliative Care Residence, and the Montreal Children's Hospital Foundation. Special thanks to the Department of Family Medicine at McGill University for their in-kind support. Here we present a strategy to mitigate potential bias. The overall program learning objectives are as follows: to review innovative approaches for the implementation of palliative care in different settings, to assess strategies to address the most important challenges in palliative care today, and to appraise the latest research in the field of palliative care. Now welcome Dr. Jeffrey Hall, neurosurgeon, associate professor at McGill University, and director of the Susan Cameron Cook Program in Neuro-Supportive Care at the Montreal Neurological Institute in Montreal. Dr. Jeffrey Hall.
Thank you. Good afternoon, everyone. Thank you very much for your attendance here, both virtually and in person. It's a day that we've been looking forward to for nearly a year. I would like to just begin to introduce our speaker for the first annual McGill Palliative Care National Grand Rounds Lecture in Neurosupportive Care, whom is Dr. Claire Crutchfield, who ticks all of the boxes for a true pioneer in our field. I have just 2 minutes to bring you into some kind of introduction, and I think she can do much more than I can in this very limited time. She's received her medical degree from Ludwig Maximilian University in Munich, Germany. She completed her neurology residency and stroke fellowship, as well as postgraduate training in palliative care and board certification in neurocritical care and training in palliative care at the University of Washington in Seattle, where she is now associate professor and practices at Harborview Hospital. Dr. Crutchfield's research focuses on integrating palliative care into the emergent and ongoing care of patients with severe acute brain injury and their families, including people who've been affected by stroke, by traumatic brain injury, and by cardiac arrest. Dr. Crutchfield has co-edited a book and has authored several peer-reviewed manuscripts on neuropalliative care, with a focus on communication and decision-making for people facing severe neurologic illness. She's written the most well-circulated textbook for clinical teaching and co-founded the nascent International Neuropalliative Care Society. Her work has been funded by Cambrian Health Foundation, National Institutes of Neurologic Disease and Stroke, National Institutes of Aging, and National Institute of Nursing Research. It was our intention to have Dr. Crutchfield with us here in person, and unfortunately, due to some global events that put immigrants and people traveling on various visas into question, it was elected that we should pursue this format to not get anybody into hotter water. However, I do want to make sure, Dr. Crutchfield, that you know that you are welcome here at a time of your choosing when the conditions permit. And now, without any further ado, we'll introduce Dr. Claire Crutchfield as our speaker for today. Thank you.
Well, thank you, everyone, for having me. I am also sad that I can't be with you in person, but it looks like everybody is everywhere over the world, and I think we will have a good hour. So what I want to talk to you about today is integrating palliative care into the care of patients with severe acute brain injury. And I currently receive funding from the NIH, and my learning objectives are here. This presentation will address these CAN-MED competencies. And so what I wanted to start with today is actually my take-home message, because I thought if anyone needs to leave early or something, this is what I want you to go home with. Severe acute brain injury is not just an event, but a chronic condition that affects millions of patients and families around the world. And to improve the lives of patients with severe acute brain injury and their families, we need longitudinal support across the range of goals of care, from curative and restorative to palliative and end-of-life care. So I will start today with the why we should care about severe acute brain injury, what research has taught us, and what Maria's story teaches us about severe acute brain injury. I will talk about the specific challenges we face, which are needs, prognosis, and goals of care. And as I get into the how, I will translate the needs, prognosis, and goals of care into those, what I'm calling the 5 A's of awareness, assistance, adjustment, acceptance, and alignment. So let's get started. Severe acute brain injury comprises all those illnesses that leave patients acutely neurologically devastated. The main players are stroke, traumatic brain injury, and cardiac arrest. And together, these illnesses account for 12 million deaths and are the leading cause of disability worldwide. Stroke alone, today, over 50 million stroke survivors worldwide are alive with disabilities and consequences from their stroke. I don't need to tell you what palliative care is, but you will know it. Palliative care is care focused on improving communication about goals of care and maximizing comfort and quality of life. End-of-life care is one smaller part of palliative care, which is the care for those who are actively dying. And so when we talk about palliative care needs, I think it is helpful to go back to Cicely Saunders' concept of total pain or suffering, and its 4 categories. This is a figure we put together for the recent scientific statement of the American Heart Association, American Stroke Association, on stroke and palliative care. And so these 4 categories of physical, emotional, psychosocial, and spiritual pain or suffering. And what I think is important here, especially for stroke, is to also distinguish between the experience of patients, the sources of suffering for patients alone, for caregivers, and for both. And then at the very core of these palliative care needs of this total pain are communication and goals of care. When I think about integrating palliative care into the care of an illness, I think it is good to think about the trajectories of these illnesses. So what you can see here on the y-axis is a patient's function from low to high, and on the x-axis, time from diagnosis to death. The, I would say, classic palliative care trajectory, that of cancer, tends to be that of the short period of decline, meaning people are diagnosed as they are functioning relatively well, and then typically have time to consider their goals of care, their treatment preferences, and their end-of-life wishes before a rather rapid decline at the end. A second illness trajectory is that of chronic illness with exacerbations, so COPD, CHF, but for neurology, it's probably multiple sclerosis would be the most common one here. Patients, again, are diagnosed when they're functioning relatively good, maybe have some time, and certainly with their acute exacerbations, some of them may require hospitalization. They might have, or those might trigger further goals of care conversations, treatment preferences, and end-of-life wishes. I think this third trajectory might be the classic for neuropalliative care because it's the neurodegenerative diseases that fit well into it. I do like to add that the other condition that fits into this is aging, and that is something that all of us have, and shows that it is harder to know when to have goals of care conversations, consider our treatment preferences and end-of-life wishes. The disease that we are talking about today is that of the 4th trajectory. And these patients with severe acute brain injury, they are diagnosed, they come to us for the first time when they're at their worst. And then at that same time, we're having to have goals of care conversations, think about treatment wishes and treatment preferences and end-of-life wishes. So what happens here is that we often only get one opportunity to get a life-changing conversation right. And these loaded conversations cover immense ground: treatment preferences, prognosis, treatment choices, patient goals of care, and all of that just to be able to come up with the right plan for each individual patient. Let me stick with trajectory. This was another figure we put together for the scientific statement and is important. You may remember one of my take-home messages was that severe acute brain injury or stroke is not an event, even though it's often thought of one. And so I'd like to spend some time, I'm just trying to move something here. Never mind. Just spend some time to think about the trajectory where that starts with the diagnosis, so the time of presentation. Probably informational needs are the main thing. The next, right after that, phase is that of treatment. So treatment after severe acute brain injury or stroke typically necessitates intubation, mechanical ventilation, questions about thrombectomy, and also that of artificial nutrition and hydration. The phase of medical stabilization is when people often move out of the intensive care unit, from a medical perspective are stable, and we're starting to have decisions for longer term artificial life support, such as a gastrostomy, a trach, also comfort measures only, trying to get goal concordant care, and disposition is discussed. The preparation phase occurs before the patient leaves the hospital. And the adjustment phase is really where the responsibility for providing care for the patient falls to the family care partners. And patients and families are learning, and they need support, how to handle care in their home environment. Adjustment tends to be more of a practical process, I would say. And then adaptation is an emotional process that, of course, should be supported early in the illness, but is particularly relevant as further neurological recovery is limited. And so that's those red lines, as that starts to sort of stable itself out. That's when people most typically are dealing with adaptation and need support with that. So I started my research in the neuro ICU and was particularly interested in how we could help patients and families during the early phase of severe acute brain injury. And so we enrolled 222 patients with stroke, traumatic brain injury, and hypoxic ischemic encephalopathy after cardiac arrest. And we also wanted to explore their palliative care needs acutely and also their long-term outcomes. Focus being on needs, prognosis, and goals of care. So to help you understand who this population was, I'm actually starting with sort of long-term outcomes. So of these 222 patients that we enrolled, at discharge from the hospital, 82 had died, 47 went to an inpatient rehab facility, 47 to a skilled nursing facility, then some to long-term acute care hospitals and to other places. Over the course of 1 year, they all experienced a large number of ED visits and hospitalizations. And when we called people at 1 year, 28 additional people had died after 43 additional ED visits and 33 additional hospitalizations. 68 people were at home, and we asked them 2 questions. The family members, does your loved one require help for everyday activities? And have they made a full mental recovery? And as you can see, the vast majority still required help and had not made a full mental recovery. Wes Plinke was my research coordinator, then medical student, resident, is actually graduating this year from residency. And he sort of measured the palliative care needs using a support checklist in the neuro ICU, asking, first of all, having clinicians ask themselves during rounds, does patient or family, do they have social support needs? Does the patient have pain or distressing symptoms? Do we need to readdress prognosis? Do they have questions about prognosis? And are we providing goal concordant care? And then he also asked family members the same question. And so what you see here, the yellow columns are the palliative care needs identified by clinicians on daily rounds, and in purple, those identified by families when we asked them privately. First observation, a lot of palliative care needs identified. Second observation, clinicians and families seem to see different needs, where the main sort of differences seem to be that clinicians are particularly interested in goals of care and feel we need to readdress that, while families are particularly concerned about their loved one's pain or other distressing symptoms. If we just took all of the palliative care needs, any of the palliative care needs identified, we looked at how those might relate to long-term outcomes. And so here what we found was that if the clinicians identified any palliative care need, that was actually associated with the families identifying goal discordance. So my loved one is not getting the care that they would actually want. And families were more likely to experience decisional regret at 3 months at follow-up. When the families identified a palliative care need, that was associated with their own symptoms of anxiety and depression at follow-up at 3 months, as well as their report of a patient's lower quality of life at follow-up. So in summary, clinicians and families see different needs. Clinicians are more focused on goals of care and may identify future decisional regret amongst families. Families are more focused on patient distress and may identify poor long-term psychological outcomes. All of those, of course, important. And so using this checklist may actually help identify people at high risk for poor outcome. I want to tell you about Maria, whose name, of course, I have changed. Maria was only 46 when she collapsed during a violin performance. She was intubated on the scene. She was comatose on arrival with pinpoint pupils. And her head CT showed probably one of the most devastating hemorrhages that people can experience, which is a pontine one, so right in the very center of, or the top of her midbrain, so the center of her brain. And so that's that white big blob that you can see. Yeah, here's my arrow. That's her pontine hemorrhage. She was admitted to the Neuro ICU, and the next morning we met with her husband and her brother, and they wanted to know what are her chances. Probably one of the most challenging and most important questions that we're asked every day. And brings me to one of my favorite books that I've read recently, and thanks to you all also read again, that can help us think about how we prognosticate, how we communicate our prognosis, and how we can update our predictions. Phil Tetlock, the author of this book, developed or found a group of what he called super forecasters. So these are people, lay people who can predict highly accurately. And he describes their success. They have competed against CIA agents they sort of have competitions and ask God, you know, will China invade Taiwan before the end of the year? Or important questions that need to be asked might be, is the unknown person in the Pakistani compound in Abbottabad truly Osama bin Laden? So these are questions where also high stakes predictions have to be made. And then on a more lighter side, predictions are made every day. How likely is it that this beautiful bride and groom in front of you at their wedding will stay together until death does them part? And one of, he describes lots of different skills that I think we need to incorporate. One of them, for example, being starting with the outside view and then tailoring to the specifics. So if you put yourself into that wedding scenario, your first reaction might be, oh, they look so beautiful. Of course, they will stay together. And that is the inside view. What you should really start with would be the outside view. How old are they? What are their demographics, statistically speaking? What are their chances of, and so on. So that would be the outside view, and then tailor it down to the inside view. So just one of those skills that he describes. And he also said, everyone would benefit if we could predict the future better. And thanks to the frankly quite amazing lack of rigor in medical forecasting, this opportunity to improve our ability to forecast is huge. Bob Holloway and I put his skills adapted them to what we think might be important for medical forecasting. I also want to tell you 3 sentences that I have said to families and that I have taught and that I don't use anymore, don't think we should use, and I will tell you why. One is he will never be the same. This tends to imply something worse than it really is, because most of us are not the same after any big event, positive or negative, and I think it's not terribly helpful. The other sentence is we don't have a crystal ball. Nobody was asking you for one. I think families are very well aware that we don't. And the third sentence is we are terrible at prognosticating. And this is an interesting one. I think we have moved from being not humble enough to maybe being a little too humble. And with this sentence, losing trust by saying that we are terrible at prognosticating, it also it tends to move people to other sources. If we're terrible at prognosticating, they will ask Google or maybe ChatGPT, and that is also something we want to avoid. I think we are terrible at prognosticating is a very general sentence and will also not help the provider who comes in a month or 2 later and then actually has a lot of data to predict with, and actually can be pretty good at prognosticating at that time. So very early on, after severe acute brain injury, we do have a wide range of possible outcomes. And so the best sort of way to communicate that we have also not optimal, but I think the best one we have is the best case, worst case scenario that you are all familiar with, because it helps describe the wide range of outcomes and potentially even the most likely. What's important here and always needs to be included in our communication is the idea is that, just like a confidence interval, really, this gets smaller over time. And we will have more data over time that can help us. And so, quoting Phil Toitlock again, forecasts are not like lottery tickets that you buy and then file away until the big draw. They are judgments that are based on available information and should be updated in light of changing information. So that means we can address prognostic uncertainty with anticipatory guidance. This is what I know now, and these are the data I will be using over time so I can know more. We may not know the end result for this patient. We may not even know the exact pathway they will take, but we are familiar with the territory. And so over time, what has changed since we last talked? The secret about prognostic uncertainty is that the uncertainty does get smaller over time, and that's where time-limited trials come into play, that we can communicate with our families. Whitney Kiker was also a medicine resident and ICU fellow who was interested in how families actually understand the prognosis that physicians give them. So using the same cohort of 222 patients with severe acute brain injury, we asked early on in their hospital stay, we asked family members, what do you think your loved one's chances of recovering to independence? Obviously, a wide range of patients, a wide range of families. On average, 54% felt the average was that my loved one has a 54% chance of recovery. And we then asked them, what do you think the doctor thinks? So already we're seeing that people are deliberately being optimistic, even though they think the doctor is more pessimistic than them. And then we did ask the doctor, the attending physician of record, and they were even more pessimistic than the families thought they were. So prognosis discordance was what the family thought the difference between what the family thought and what the physician thought. And if that was more than 20% difference, which was definitely a difference, we found that it occurred for 61% of patients. And it was also significantly more common among families of racially minoritized groups. We also looked at what we would call misunderstanding, maybe. So the family thinks what the doctor says is different from what the doctor actually says. That was present for 46% of patients. And then what we call difference in belief, optimistic, was present for a little over 50% of patients. And these are people who openly said to us, I think this, but I think the doctor said that. So we asked them, what do you think explains the difference? And their answer was often faith and uncertainty. If we can't know, if there's uncertainty, we must be optimistic. There must be more hope. And we asked another question here. We asked the nurses and the attending physicians, how would you rate the family's understanding of prognosis? And what we found, and then we dichotomized their answer into poor or fair versus good and excellent. If the nurse rated a family member's understanding of prognosis as poor or fair, that was significantly associated with misunderstanding. So if a nurse tells you, I don't think they get it, they probably don't. When the physicians said, rated the family's understanding of prognosis as poor or fair, that was significantly associated with a difference in belief. So if a physician tells you, I don't think they get it, they actually might get it. They are choosing to be more optimistic. So in summary, prognosis discordance between physicians and families after severe acute brain injury is common. Efforts to improve communication decision-making should aim to reduce discordance and find ways to target both misunderstanding and belief differences. And let me get you back to Maria. We had a question for them. What would she want? And as Gretchen Schwartzy and Toby Campbell will tell us, that is also not quite the right question to ask, and this is why. Asking families what their loved one would want tends to focus the conversation more on treatment versus on goals. She would want to be resuscitated. She would want a PEG tube. It can shut down conversation because once you've established that you would want a PEG tube, it's hard to sort of move on from there. And the third argument, which is why this unicorn is on this slide, is that want is aspirational and evokes fantasies. And they argue that just like if you ask a child what they want to be when they grow up, it implies that anything is possible. And so the simple recommendation here is to, rather than asking them what you would want, might be to ask them what you would say. So if she could sit here with us or could hear what I just said, what might she say about all of that? And I will add, oh, I didn't put it in there, but I was going to add effective forecasting is the next sort of problem with this question, which is, how do we know what she would say? How do we know what she a few months ago would say, and how can we know how she might think about it in a few months from now? And this is a dilemma that I think is just a hard one to get at. And so we put together this, Bob Holloway and I wrote this viewpoint where we asked more questions than gave answers, I would think, but really thinking about how do we address goals of care about a situation that we cannot anticipate. And there are ethical questions, for example, what is true informed consent, given the complexity of the information that we might share? Should past and future values be weighted equally or differently? It's probably different by person. And then how do people adapt to new health states? Can we predict a patient's ability to adapt? And then how do we, what could interventions be to improve this? Educational interventions or could high quality decision aids help us reduce this dilemma? Rachel Roth-Swoumar is a palliative care physician in Lausanne, Switzerland. She came and spent a year with me as a postdoc and was interested in this adaptation idea. And if we ask about goals of care early on, how do people think of those later? And so here's what we asked that same group of 222 family members of 222 patients. We asked them early on, looking at 6 months or so from now, how much better does your loved one need to get so that you would feel that all of this medical care was worth going through? And we gave them 5 options: as long as she survives, even if unconscious; as long as she's awake, even if with limited interaction; she would feel this would only be worth it if she can think and communicate, even if it's not quite the way she used to be. No, only if she returned to her previous normal cognitive abilities, and I don't know. As you can imagine, the line drawn after severe acute brain injury was often only if she can think and communicate. 61% felt that. But a few people were also had put the line below that. So we were interested in this group. So only if she can think and communicate or better. And we followed these patients along. And so of these patients, 41% died in the hospital. Of course, the vast majority after a decision to withdraw life-sustaining treatment. And then we had 83 survivors, most of which, 60% of them, survived to a place that was worse than think and communicate. So survived, but were not able to really think and communicate, interact meaningfully with their environment. And those were the people that we interviewed. We interviewed their family members because we were interested in what we called adaptation. And here's what we found from these interviews: 2 main themes. The first one was they were trying to adapt to a new normal, but seemed to be hindered by uncertainty, even many months later, many months. And we still haven't given up hope, is one quote. It's 9 months, and we were told that a year's time will show the improvement that they will make. And everybody's different, Or another one said, it's been hard to make any kind of plan. It's been hard to know where we're actually going to end up and what we're going to need. And the other theme was that people were asking for support and guidance and not getting it. We're looking after a year's time, where does he go from here? And if he doesn't get better, do we let him go? Or that'd be really nice to have someone say, these are your options for the future. This is when you should be concerned enough to put her in a home or to make decisions for her. So in summary, most survivors of severe acute brain injury survived to a state that their families initially thought would not be acceptable to them. And survivors and their families need more support and guidance as they adapt to a new normal and struggle with persistent uncertainty. Maria started following a few commands in the hospital. And so she was discharged with a trach and a peg. She had very resourceful family members who knew where to go and just to advocate for her. Was able to go to an amazing rehab facility. Her orchestra, don't worry, these are not real pictures of her. They are mostly from the internet. Her orchestra did a fundraiser to buy a wheelchair accessible van, so she was able to get out, and she was rehospitalized a few times for respiratory distress. I met with them about 3 months after discharged. She was awake. She followed commands. She was unable to move her entire right side. And while able to move the left side, it was very, very discoordinated, which is from her cerebellar dysfunction. She had only vertical eye movements, was unable to look horizontally, and significant dysarthria, so trouble speaking, and dysphagia, trouble swallowing. I told her about the conversations that we had had, that I had had with her family, and wondered what she might think about those now. And she answered haltingly, "I am glad and I am sad." She was grateful for the time that she had and was trying to keep recovering. Over the next few months, she was able to see her favorite violinist performing in the rehospitalization, and she was able to get outside, and the rehospitalizations were unremitting. So they found themselves in sort of this adjustment and adaptation phase. I think there are two things that I need to add to my trajectory. The first one is that of alignment. How can we align what is most important to people at the beginning and over time? And what many people tell us is that this red line is their neurological function that tends to stabilize over time, but everything else in their world is a roller coaster. We know that family members of patients after severe acute brain injury have high levels of psychological distress long time down the road. And so they need support longitudinally, and that is not happening in the current healthcare system. So we developed an intervention that tries to address exactly that tries to address the needs, prognosis, and goals of care. And we're currently trialing this intervention in a pilot randomized trial. It's called the Lotus intervention because, as you know, the lotus flower grows from mud and is very beautiful. So longitudinal transdisciplinary neurosupport. This is a nurse-led intervention. The nurse follows families of patients and their families after severe acute brain injury and has in their backpack a social worker, a chaplain, a mental health provider, and a neuropalliative care physician. And the concept here is that of the 5 A's, and it's a stepped collaborative model starting at the bottom with awareness and assistance. So using, for example, checklists to be aware of the needs on a regular basis, these checklists, so explore these needs in all our dimensions and assist with them. Adjustment is this, how can we adjust someone's environment and healthcare system to what they need? Acceptance is mostly a sort of a psychological intervention. We used a concept from dialectical behavioral therapy called radical acceptance, helping people adapt and accept, and with this idea that only with radical acceptance can we actually find alignment. The Lotus team continued to support Maria and her family. As the anniversary of her stroke drew near, she had actually had a pretty rough few months with hospitalizations for aspiration pneumonia, and that they actually hadn't experienced in a while, a couple of intubations as well. And recognizing that the frequency and severity of these hospitalization was not going to decrease, they decided to go on hospice. And she actually did really well for a few months at home until a few things came to a head and she died at home on hospice. So what I wanted you to take home today, and I hope you will, is that severe acute brain injury is not just an event, but a chronic condition that affects millions of patients and families around the world. And to improve the lives of patients with severe acute brain injury and their families, we need longitudinal support across the range of goals of care, from curative and restorative to palliative and end-of-life care. I want to thank a ton of people. These are just representatives of the nurses in the neuro ICU. Randy Curtis, who was my mentor and advisor and critic and cheerleader, and who I miss very much. Other mentors, Ruth Engelberg, Bob Holloway, and Will Longstreth, who still gets an award for not having a picture of himself on the internet. And I will end with that.
Or comments? Okay, we can go ahead with this. All right, there's a question from the Zoom. Could you comment on recovery and how long might one expect functioning to stabilize and level out in a person recovering with a stroke?
Yeah, I think that is obviously exactly the question that people ask us and that people need to know. And you will hear from many stroke survivors that they continue to recover many years even after their stroke. So, and I think we should see that just like language is easier to learn early on when we're, when we are young and harder as we get older. And similarly, it seems that recovery occurs a lot early on and less over time, which doesn't mean it doesn't later on. What I think is important to use and what narrows this best case, worst case sort of confidence interval is the trend. And people who have not made much of recovery will probably not make much more of a recovery. And so the biggest milestones we tend to see in the first 6 months or so. But I think what I was a bit sad about was what we heard regularly from family members was that even at 9 months, their family member might have still been comatose. And they said, but we have until a year, don't we? Because that's what people told us. And if someone has not made, sort of their recovery has been stagnant for many, many months, we don't expect any bigger milestones.
Another question. What's your approach when primary care teams like neurology, neurosurgical teams tell family members that we will never really know functional recovery and sometimes things can reveal themselves in a year?
Yeah, I think what's important here is that, and that's why I'm really advertising for this longitudinal support, is that right now, what I can tell you is this, and I think we're still facing a broad range of outcomes. Even there, I will say, when we need to remember what people hear when we say that. So if I just say broad range of outcomes to someone who's had a huge left hemispheric stroke, they think, oh, he can walk and talk again. No, he won't be able to walk, at least not normally again. So again, sort of trying to remember what we're saying and what people are hearing. So that's maybe my first thought, that when we communicate uncertainty, we need to know what people are hearing. But really your question was, how do we communicate? Wait, what was the question? If we can't know exactly, then let's think about what is most important to your loved one, what is worth fighting for, and let's see what things we might need to see over the next month or so that it seems likely that those things are going to happen. So longitudinal support and keep updating our forecasts, like Phil Tetlock said.
Thank you. Is a patient decision aid under development to incorporate these findings and considerations? You understand the question?
Yes, I see it from an anonymous attendee. Please let me know if you have ideas about it. I think this idea of decision aids was a big one a few years ago, and the reason I personally at least have been not excited about them is that they tend to be very cognitive, and I'm not sure, and they tend not to include the emotional support and trust that we need to build with people as we as we sort of move along with them. So I think a decision aid tends to cognitively explain, what a peg in a trach is, for example, but we'd have to figure out how a technical support aid could provide all the things we need.
Thank you. Another question. If families reduce or remove medical interventions over time, do some struggle with feeling responsible for their loved one's state or death rather than, say, the medical condition, which I imagine would be easier to accept in the earlier stages, but I could be wrong about that?
No, I think you're exactly right. And I think that is our job to communicate that with them. And I hope I made that clear when I talk about people dying after withdrawal of life-sustaining treatment. I do not think that the cause of their death is the withdrawal of life-sustaining treatment. The cause of their death is their severe acute brain injury, and that's what caused their demise. Especially, and I often say that to families, especially in this modern day and age where we can theoretically keep people alive as long as we want almost, it is still the illness that is, at some point we're the ones who need to say stop, but it's still the illness that is taking them. And I do think that's an important piece that we need to communicate with our families.
Thank you. And we'll take last questions from Justin Sanders.
Hi, Claire, this was a beautiful presentation. I'm curious about, in thinking about the sort of model of total pain that you described and the nurse-led intervention, I'm curious about how you think about incorporating other members of the interprofessional team into the Lotus intervention or sort of bringing their voices in, because I think we know how important that is, and yet these resources are under threat in many institutions, and so I'm curious how you think about that.
Thank you, Justin. What a wonderful question, because obviously that's what the T in Lotus stands for. And you're right, I sort of, in my talks, emphasize more the longitudinal part, but the transdisciplinary is key. And we have so many examples right now in our pilot trial that if you do have me back, and this time in person, I will tell you about. But this nurse is, I feel it's probably important to have one sort of main person. So the nurse is the main contact person for the family, but trained by the other Lotus team members. We meet every week and discuss cases as the Lotus team members, and depending on individual needs, individual Lotus team members are sort of brought to individual families for that. And that's of course also a bit of a budget question. Ideally, you would have full-time of all of them. We actually only, right now, we have a full-time nurse and 5%, which is 2 hours a week for each of the Lotus team members. But it means that they have 1 hour a week that we discuss cases, and each one of them has another hour that they can spend with a family if that is felt that is needed.
That's really helpful. Well, I will just say that this concludes the Neurosupportive Care Lecture in the McGill Palliative Care National Grand Round Series at the Montreal Neurological Institute and sponsored by them on this occasion. We are so grateful to Claire for her expertise and her time with us today. I think the question is not if you come to Montreal, but when. And so we will look forward to that time when as soon as possible. We ask that participants please complete the evaluation form. The QR code was available previously. The link is also available in the chat if you're still with us, so that you can obtain your accreditation and so that we can gain feedback on the series. And yes, so I'll leave it with that and pass to my colleague.
We look forward to seeing you again next month on May 21st, when Dr. Camilla Zimmerman will speak at Cedars Cancer Center. Thank you, everyone, and à la prochaine.